Hi, everyone. Welcome to another multi-heart lecture series. It's a great pleasure to have today Dr. Mario Gaudino from Weill Cornell Medicine, who will be speaking about revascularization choices among underrepresented groups evaluation about the RECHARGE trial. And today we will also have Dr. Greg Stone that will be joining us and will do a shared presentation. I would like to start by giving our prayers to people in Los Angeles. I train at Cedars-Sinai, so there's a lot of people that I love that are there. So hopefully things resolve fast. And then let's move to the introduction. So Dr. Mauro Gaudino is a Stephen and Susan Weiss Professor in Cardiothoracic Surgery in the Department of Cardiothoracic Surgery at Weill Cornell Medicine. He completed his undergraduate studies and earned his medical degree in Rome, Italy at the University of Rome. In 1994, he subsequently completed his residency in 1999 at the same university and joined the faculty there afterwards. He remained there until 2014 when he joined the Department of Cardiothoracic Surgery at Cornell Medicine. And then he completed an advanced cardiovascular aortic surgery fellowship in 2016 and was recruited to join as staff later on. In addition to his clinical expertise, Dr. Gaudino is currently the Assistant Dean for Clinical Trials, Director of the Joint Clinical Trials Office, and the Director of Translational and Clinical Research for the Department of Cardiothoracic Surgery. So in his academic career, Dr. Gaudino has published more than 730 peer-reviewed manuscripts in cardiothoracic surgery, cardiology, and research methodology, and public health, including high-impact journals such as New England Journal of Medicine, Lancet, and Journal of American Medical Association, amongst others. So on top of this, we have today also Dr. Greg Stone, who is the Director of Academic Affairs for Mount Sinai Health System and Professor of Medicine and Population Health Sciences and Policy at the Sina and Michael Weiner Cardiovascular Institute at the Icahn School of Medicine. Dr. Stone doesn't need an introduction, but he's a leading expert in interventional cardiology and one of the most widely cited researchers in science. He has served as a PI for approximately 130 national and international multi-center randomized trials, has delivered thousands of lectures internationally, and has authored more than 2,500 book chapter manuscripts and abstracts published in peer-reviewed literature. So it's a great honor to have this amazing group of speakers today. So thank you very much for taking the time.
So thank you very much, Leandro, for having us. And I think it's a very exciting time with Montefiore in the final stage of the process of joining the RECHARGE trial. And so we are delighted and honored to have the opportunity to talk a little bit more in details about the rationale and the design for this trial. As you have mentioned, I'm honored to share this lecture with my friend and co-principal investigator of RECHARGE, Greg Stone. And we will essentially split this relatively short presentation in two parts. In the first part, I will provide a background and rationale and just explain why after 20 years of clinical research, we are doing another PCI versus CABG trials. And then Greg, in the second half of the lecture, will go over details of this new, highly innovative trial that we have designed. So let's get started. And the single most important reason why, despite, again, 2 decades of trial comparing PCI versus CABG, we felt as a group that another PCI versus CABG trial was needed. The single most important reason has to do with the disparity that currently exists in the quality of care that the patient in need of coronary revascularization receive in the United States based on their sex, race, and ethnicity. I did something wrong. So just as a recap, we all know cardiovascular disease is the leading cause of death in the United States. with over 850,000 deaths every year. And coronary artery disease account for approximately 40% of all cardiovascular deaths. Over 400,000 cardiovascular deaths occur in women and over 170,000 in Black and Hispanic patients. So this gives you a sense of the size of the problem. Coronary revascularization, as we all know, is a very common procedure. It's actually among the most common hospital-based intervention in the United States, with over 860,000 per year. But probably if we added a single-day PCI procedure that are not captured, we are well over 1 million of procedures per year. And of those procedures, approximately 250,000 are performed in women, and approximately 200,000 are performed in patients from racial or ethnic minority group. Despite that, the reality is that we do not know too much about the relative outcome of PCI and CABG in women or in non-white patients. This table summarizes the proportion of women and non-white patients who were included in seminal PCI versus CABG trial over the last 20 years. And it's obvious how women represented the minority, generally between 25 and 30% of the patient included. And the representation of non-white patient was even lower and in the single digit when it was reported. But most of those studies did not even report the percentage of non-white patients. So the reality is that today we only have solid information for the comparative effectiveness of PCI and CABG in white men, because white men did represent the majority of the patients enrolled in previous PCI versus CABG trial. And there is no randomized evidence from dedicated study on the result of PCI versus CABG in women and in non-white patients. And this is highly problematic from a clinical and decision-making standpoint, because we do know from registry study that the outcome, the result of both PCI and CABG are not the same in women as compared to men, and in non-white patients as compared to white patients. As an example, those are two large individual patient data meta-analysis comparing the outcome after PCI, one IPDMA, and CABG, the other IPDMA, based on sex. And it is obvious how women had worse outcome than men, both after PCI and CABG. So translating what we know of the comparative effectiveness of PCI and CABG in men to women, it's wrong and potentially misleading. And very similar result when we analyze the outcome of the two interventions based off race or ethnicity, with non-white patients consistently having worse outcome as compared to white patients after both PCI and CABG, and Black patients in particular having significantly worse outcome after both PCI and CABG as compared to white patients. So in essence, from women, for women and for patients who are from racial and ethnic minority group in need of coronary revascularization, and this is not a small number, it's over 350,000 patients per year in the United States. For those group of patients, the data that we use to inform key treatment decision are lacking, or even worse, potentially misleading, because what we are doing, we are applying data derived from white men to women and non-white patients, when we do know that the outcome of those groups are not the same. That's why, and this was the most critical reason why we as a group thought Greg, myself, and the steering committee, that the PCI versus CABG trial in women and racial and ethnic minority was urgently needed, and this is why we designed Recharge. The second issue that we wanted to address with Recharge is partially more methodological in nature, but still has important clinical implication, and has to do with the limitation of the classic composite outcome used in previous PCI versus CABG trial. It's what we familiarly defined the MACE outcome, so it's a composite of cardiovascular outcome that generally include the death, MI, stroke, with or without repeat revascularization in different iteration. So this composite outcome it makes no doubt the trial design, sample size determination, and analysis very easy. As a trialist, I do like it because it makes my work extremely easy. As a clinician, however, I think that this composite outcome makes no sense. And we will see why it makes no sense. The first and most important reason is that MACE, in the form that it has been used in all previous or almost all previous cardiovascular trial, essentially equate all events that are part of the composite outcome are given the same weight. But we know that repeat revascularization is not the same as MI, or spontaneous MI is different than periprocedural MI. And so giving all those clinical events with very different impact on patient life the same weight just doesn't make clinical sense. And it is even worse than that, because all previous trials use the time to first event analysis. And so when you use a time to first event analysis, events that happen earlier in the follow-up have a larger impact on the composite outcome as compared to events that happen late in the follow-up. So if we think, for example, of perioperative myocardial infarction, well, perioperative myocardial infarction is an event whose clinical implications are still debated. Like, we don't really know what is a clinically meaningful perioperative myocardial infarction, but by definition is an early event. And so perioperative myocardial infarction will have a larger impact on the trial outcome that, for example, death, because mortality is generally a late event. And again, as a clinician, I don't think this makes any sense. And even within the same subcategories of events, there is a large spectrum of clinical severity that is ignored using the classic MACE outcome. We have already described how not all MI are the same, and spontaneous MI and the periprocedural MI are very different. But we can apply the same logic to stroke. There are some stroke events that are essentially asymptomatic and that we capture only because we are doing brain imaging. They have no effect on patient life. But on the other hand, there are also very severe, very large stroke who have a very severe clinical consequence. So grouping all them together, giving all those events the same weight, again, it's clinically meaningless. And also, a key issue with MACE is that it's only limited to the cardiovascular system and ignore non-cardiovascular events that are as important, or arguably even more important for patients, than some of the cardiovascular events that are included in MACE. And We see a list here on this slide: infection, sepsis, vascular complication, bleeding, chest pain, but also cognitive decline, depression, time to recover. And some of those non-cardiovascular events may be related to the intervention, to PCI or CABG. And so ignoring them to focus only on cardiovascular event makes, for the third time, has no clinical sense. So that's why with Recharge, we really wanted to take the patient perspective, not the trialist perspective. Greg and I always say this is the first time a trial is designed for patient, not for trialist. And we really aimed at providing patients with the information they want and they need to make informed treatment decision. And this is challenging because this is all the data from John Sperter's group, but we do know that the perception of individual clinical event is very different when you compare physician or trialist to patient. The expectation and the hierarchy of clinical event is perceived very different by those groups. And while physician and trialists tend to focus more on discrete clinical events, such as, again, MI, stroke, revascularization, patients essentially care about quality of life. But quality of life has generally been ignored or relegated to secondary outcome in all previous PCI versus CABG trial. So when developing Recharge, a very important goal, in addition to filling the gap of information for women and non-white patients, was also to develop a novel composite outcome instead of MACE that could describe and include all early and late events after both the intervention, represent the risk and the benefit of each procedure, overcome the limitation of the previous MACE composite outcome that I've just described, and in essence, reflect what matters most to patients: to live longer and live better. Doc, how long and how well will I live after the intervention? And Greg will give you the details of how we think we have achieved this very important goal. So with that, this is the first part of my presentation, and I think I suggest, in the interest of not also time but logic, maybe rather than stopping here, we can have Greg presenting the second part, and then we have a Q&A at the end. So, Greg, please go ahead.
Great, thanks. So next slide. So the Recharge trial is really a program. There's actually two parallel, each separately powered, multi-center, one-to-one randomized open label superiority trials. We're calling them Recharge Women and Recharge Minorities. The first in 600 women of all races and ethnicities, and the second one is 600 Black and Hispanic patients. And there'll be a little bit of overlap between some of the patients, obviously, who are, for example, women and Black or Hispanic. Next slide. So the major inclusion criteria are really pretty simple. Patients have to be either female sex and or Black race or Hispanic ethnicity, and that's self-identified. Female sex is biologic, Black race or Hispanic ethnicity is self-identified race and ethnicity. All the patients have to have multivessel or left main coronary artery disease, and revascularization has to be indicated by the local heart team, and there has to be equipoise between PCI and CABG. Now, what do we mean here by equipoise between PCI and CABG? That's actually pretty important. We've got a lot of information from our prior trials as to who does better with PCI, as to who does better with CABG, at least for the classic MACE endpoints. But all of that is really based on data in mostly white men. We really don't have similar data in women and similar data in Black and Hispanic patients. And as Mario showed you, all three of those groups are higher risk than white men. And there are, socioeconomic and other factors that may differentially affect their response to PCI versus CABG than in white men. And also, when we're really focusing on now the endpoint that's really important to patients, that is not only living longer, but also living better with a higher quality of life, we really don't know between PCI and CABG which is better. We know that in general, there's going to be faster recovery and less of a hit on quality of life, especially for physical dimensions of quality of life after PCI early. But a bunch of trials, again, primarily in white men, have shown some modest advantages of CABG late. And we really have no idea what that's going to look like in women, Black or Hispanic patients. So we're asking you to cast a wider net here than you would based on your data from MACE in white men. That is, if you've got two or three relatively, multivessel or left main disease, let's say isolated left main disease that you'd normally do PCI on, or multivessel disease with two or three simple lesions that you normally do PCI on, that is a very, very valid patient to randomize in this trial for those reasons. And we just don't have data on those outcomes in female sex, Black race, or Hispanic ethnicity patients, especially when we're looking at a death and quality of life outcome. And similarly, if you've got some high syntax score patients or diabetic patients that you'd say, well, gosh, if that was a white man, and if I was really interested in MACE, I'd probably send them to CABG. We'd also like you to think broader here because we don't have data on how women, Black and Hispanic patients will respond to that, even with high syntax scores, PCI versus CABG, especially with a long-term outcome that is really going to emphasize quality of life. So cast a much broader net than you really would in a normal PCI versus CABG trial based on past data, because we don't have a lot of informative data at all. Next slide. The major exclusion criteria, there's relatively few. STEMI within 33 days, cardiogenic shock, prior PCI within 1 year, or prior cardiac surgery anytime. Need for any cardiac surgical or interventional procedure other than coronary revascularization or left atrial appendage occlusion. If you want to do a procedure and either in the same procedure or a subsequent procedure, you want to put in a Watchman device or an Amplatzer and close the left atrium, or if the patient's going to go to surgery and they want to exclude the left atrial appendage, then you can do that. But any other procedure, such as excluding an aneurysm or replacing a valve or repairing a valve, either transcatheter or surgical, those are excluded. And then finally, life expectancy shorter than 3 years due to concomitant non-cardiac conditions. So again, very few exclusion criteria because we really don't know who's going to do better or worse in this patient population with an emphasis on long-term quality of life. Next slide. So follow-up duration. The trial has been funded for 7 years. And so trial activities will last for about 6 years, including a 1-year startup. So there's two phases. There's a pilot phase, which is the first 2 years, and we're in the pilot phase right now. And this is really critical for us to enroll a substantial number of patients during the pilot phase to show that the trial is feasible. So PCORI will then grant the funding for the final phase. And the full trial then is an additional 5 years. And we're on track to do that, but we've got to keep our eye on the ball. We fully expect to achieve that, but that's also why we need Montefiore's help. We're consenting all, no, go back, please.
Sorry.
We're consenting all patients for 10-year follow-up. Okay, so we are expecting that we will be able to receive an extension grant to be able to do 10-year follow-up and 10-year analysis. That's not guaranteed, but if this goes well, it's such a unique study. The same way ischemia got a 10-year follow-up grant, we expect to get a 10-year follow-up grant. and all patients are consented upfront for that. But the primary analysis will be performed at 5 years, and we will use all available data at that time, and it will be analyzed at the time when the last enrolled patient reached a minimum of 3 years follow-up. Next slide. Now, as we mentioned, there's a lot of emphasis on quality of life in this trial. And this shows you all the different quality of life scales that we're going to be assessing. And you can see there's like 7 of them, and how many times we're going to be assessing them during follow-up. It's really frequent. However, there's really good news for you. And that is, other than the baseline assessment, all the follow-up assessments are being performed by a independent follow-up unit, blinded to randomization, that was not at all participating in the trial enrollment. And this is a study group in Kansas City, which is led by John Spertus's team. And so we are employing them to do all of these follow-ups. And they're also going to do all the clinical follow-ups. So they're not only going to ask all the quality of life questions, they're going to ask the patients, how are you feeling? What medications are you taking? Have you had any hospitalizations, etc. So what do the sites need to do? The sites need to do all the baseline assessments in terms of the quality of life scores and all the demographic data, clinical data, etc. All the in-hospital outcomes. The sites need to do all that. Send the films to the angiographic core laboratory, etc. All until the time of discharge. Then after that, the follow-up team will take over. If the follow-up team does find that there was a hospital admission, the follow-up team will communicate with the site and ask you to then collect source documents to send to the clinical events committee. Also, we'll be asking you at yearly periods to also do a assessment to find out whether or not any patients have been hospitalized according to looking at Epic or the medical record. And then finally, at 1 year, there's also a repeat echo and repeat blood work. The patients don't actually have to come in and see any coordinator, but we are requiring you to help coordinate that follow-up visit so the patients do get a follow-up echo and do get their follow-up blood work. But the bottom line is 95% of all of this follow-up is going to be done by the independent follow-up center. And so it's much, much less burden on the clinical trial center than usual. Next slide. So what are our main outcome measures? Our primary outcome is the composite of all-cause death and the mean time average change in generic quality of life from baseline during follow-up, assessed by the SF12 version 2 instrument during the entire follow-up period. And again, we're calling a meaningful difference at least 5 points. We're testing this by a Finkelstein-Schoenfeld win ratio analysis. So it's basically survival and improvement in quality of life, which is what patients care about. And the type of quality of life, the SF12 is a generic quality of life. It's overall quality of life. It's not just saying, are you making angina better? It's saying, how are you overall feeling? How is your life? How are your daily activities? How are your interactions with your family? How is your mental functioning? It's everything, because we want to reflect not only the cardiovascular risks and benefits of PCI and CABG, but also all their kind of off-target risks, some of which can be iatrogenic, from both procedures. So, for example, if a patient has a vascular complication and has an amputation, that's going to have a major effect on their overall quality of life, but it's not going to have much of effect on their angina frequency. And so the primary endpoint's looking at overall quality of life. We do have a powered secondary outcome, though, which is disease-specific quality of life, and that is the relief of angina, as assessed by the Seattle Angina Questionnaire. Now, I say that this is time average change in quality of life. So what do we mean by that? It means that we are not only looking at quality of life at individual time periods, like at 1 month or at 6 months or at 3 years, the way other studies have done, but we're averaging the quality of life over the entire study period to reflect the patient's journey, if you will. So go to the next slide. and I'll show you what that means. So here you can see these show you all the different time factors that we're assessing quality of life, and it's very, very frequent. And basically, we're assigning different weights to each of those assessments to reflect the gap in between the number of months. And so we're going to add up the quality of life measures, and we're going to give them a weight for each of those individual measures, and then we average them over the whole time period. So it's really going to be kind of an average quality of life, kind of the area under the curve over the 3 to 7 year follow-up period for the primary analysis. Next slide. So for those of you who are not super up on what the win ratio is, okay, this is a hierarchical ranking. This is the primary endpoint for death and the change in quality of life by at least 5 points. So what you actually do in the win ratio is you compare every patient in the PCI group to every patient in the CABG group. And you compare them each during their longest common follow-up duration. And of course, follow-up durations can vary if patients are lost to follow-up, or if they withdraw from the trial, or if they die. So let me give you some examples of how this works. So click one time. So here's one pair of patients, from patient A from the PCI group, patient B from the CABG group. And you can see that patient A dies, that's the red dot, after a certain amount of follow-up time. Patient B has longer term follow-up, but we only follow up the patient up until the shortest common follow-up duration. Okay, so it's basically until that time where patient A died. We look at that common follow-up period. Now, in that time, you can see patient A had an improvement in his or her quality of life by 15 points, and patient B had an improvement in his or her quality of life during that time period of 5 points. But the top of the hierarchy is death. So we first asked during that common follow-up period, is there a difference of death? And there is. As you can see, patient A died. So in this patient pair comparison, patient B wins. We don't even care about the quality of life difference because death is ranked as more important than quality of life. So in this case, patient B wins. Next slide. Now here's another pair of patients. Here you can see both patients die, but patient B dies before patient A. We don't care about the quality of life again because there's a death. So here patient A wins because patient B died earlier than patient A. Next slide, or click again. Now here there's a case where there's no deaths, okay? But here you can see the two patients are censored with the diamonds at different time periods. So we take that longest common follow-up duration, which is limited by patient A. And here patient A improved their quality of life by 12 points. Patient B improved their quality of life by 5 points. That difference of the difference is 7 points. So here patient A wins because they've got a 7-point difference. And then finally, if you go to a fourth patient pair, here you can see, again, there's no deaths. Here you can see, though, the improvement in quality of life is 7 points in one, 6 points in the other. So that difference of the differences is 1 point. That's considered a tie. And that's because the delta of the delta is less than 5 points. And then what we do is we add up all the wins in patient group A and all the wins in patient group B, and the ratio of those two is called the win ratio. Next slide. Now, we have major secondary endpoint, as I mentioned, and that's going to be disease-specific quality of life using an analysis of covariance from baseline. And then we got a lot of tertiary endpoints that are not specifically powered, but we are going to look importantly at all major adverse events. And we're not only going to look at the 3 or 4 that prior studies have looked at, death, MI, stroke, and repeat revascularization, we're going to look at 20. And we're going to adjudicate all 20 of those adverse events, including vascular complications, new development of chronic kidney disease, major bleeding, AFib, all hospitalizations, reoperations, et cetera. And we'll look at the relationship of those events on the impact of subsequent mortality and worsening quality of life. We're going to look at days alive and out of hospital, Other quality of life outcomes that are not in the primary, secondary endpoint, mental functioning, return to work, activities of daily life. We'll look at major subgroups, including the social vulnerability index, to see how much that affects outcomes. Outcomes according to physician and patient pre-randomization preferences, and the impact of PCI versus CABG on the caregivers, as well as on the patients. Next slide. Again, many subgroup analyses. We want to really look at the impact of a socioeconomic status. There's a lot of data that the worst outcomes in both Hispanic and Black patients may totally be explained by socioeconomic status and not by biology. And so we're going to be looking at that in detail. Again, there's a very detailed instrument called the Social Vulnerability Index. We'll be looking at a level of education, total household income, et cetera. We'll also be doing in-depth analyses in women, and we're adding about 20 very detailed questions to the case report form to explore the impact of gravitas status, use of hormone replacement therapy, polycystic ovary disease, et cetera. Next slide. So we're really fortunate, while Mario and I are the PIs, we're really fortunate to have put together an absolute world-class group to answer these questions. The co-principal investigators are Ruth Masterson-Kreber from Columbia, Bjorn Redfords from Cornell, and John Spertus, who basically is the father of quality of life, developed both the KCCQ and SAC, and Clyde Yancey, who has spent a career, really in a leadership position, looking at all of the diversity-related outcomes in medicine. If you look at who the steering committee is, the co-investigators of this study, again, I won't go through it name by name, but we've got an incredible group of people, male, female, white, Black, Hispanic, non-Hispanic, who are leaders in all aspects of this field, including medical statistics, underrepresented patients, clinical trial design, et cetera, PCI and CABG. And we have a stakeholder leadership committee, which is really made up particularly of patients and public representatives, such as reverends from the community, women's advocacy groups, others who are really looking out and considering all the patient outcomes in this trial. So this is an extraordinary group that we're working with here. Next slide. So finally, Recharge was funded by the Patient-Centered Outcomes Research Institute. That's PCORI. That's a government organization that's separate from NHLBI. It was funded as a phased large award for comparative effectiveness research with a $30 million grant. So it's a PACER award. The protocol has been finalized and the central IRB is approved. We have 82 sites that have been selected in the United States and Canada. And actually, as of today, we now have 21 patients that have been randomized in the trial. So we're really getting going into phase 1 here, and we'd be really thrilled and honored to have Einstein Montefiore take a real leadership role in the Recharge trial, first through enrollment, and then as you really demonstrate enrollment, again, we're going to be expanding leadership opportunities for sites that have really demonstrated that they're really committed to the trial. So I believe that's my last slide, and these are the official Recharge cats. We have official Recharge cats and Recharge dogs. Thank you.
Thank you very much. That's very important work you are doing, so we're very excited to join you with it. So we have some time for questions now, so please put your questions in the Q&A. And we have also Azim Lativa join us and Mario Garcia. Would one of you, Azim or Mario, would like to start with the first question?
Yeah, let me start with one. I apologize, my camera is not working here. I hope you can hear me well. First of all, I have to say this is a very exciting trial and an incredibly novel methodology. In fact, just last year, there was a paper published in the European Society of Cardiology. You probably aware of the Sweetheart Registry that suggested that surgery has an advantage over PCI for and STEMI. But when you look at the characteristics of the trial, basically has pretty much all the limitations that you listed at the beginning of your methodological presentation, including obviously the narrow constitution of the population that was studied. But I would like to hear your comment on that particular trial if you want. But I had a couple of questions for you, just out of curiosity, why not to include other minorities, like, for example, here in this area, Bengalis and other Asian communities? Other question, this is a little more on the practical aspects of it. In what bucket do you put a Hispanic or African American woman? In the woman category or in the minority category? And the final one, I have a little bit of a confusion about the win ratio. I mean, you're certainly comparing in your examples the survival versus quality of life, and obviously I think most of us would agree that survival is more important, but how about survival versus a debilitating stroke, which is really clinically more relevant to survive with a debilitating stroke or limiting so much of a limitation in quality of life, or to live for a period of time healthy?
So maybe I can take that question or those questions, and I'll go from the last to the first, and I'm usually good at remembering one question, so you'll help me if I forgot. So again, as Mario showed you, there's all sorts of different strokes. There are strokes that might leave a patient hemiplegic for their entire life, which is obviously has a massive impact on quality of life and will lead to early mortality. And there's other strokes where somebody will get numbness in their leg and it might go away in 2 or 3 days. That'll have almost no impact on the rest of their life. And trials that count strokes don't differentiate those two. And strokes are also relatively infrequent. So the impact of stroke and the variety of the strokes will have an impact on quality of life that'll be variable. And we'll also, again, as a secondary analysis, be looking at what was the impact of stroke on change of quality of life in both arms. So that's why, quality of life basically encompasses all types of outcomes, large and small MIs, major kidney disease requiring dialysis over time versus a minor change in creatinine, which we might call both of those CKD. So basically that's that rationale. Now, in terms of your second question, initially, we thought it would be harder to enroll the Black and Hispanic cohort compared to the women cohort. So initially, if a patient is both a woman and Black or Hispanic, initially they will get stratified as into the Black or Hispanic bucket. And then we can adjust that over time. But the bottom line is that women, whichever they get stratified in, are going to count in the women category, and Black or Hispanic patients, whichever they get stratified as, will also count as being Black or Hispanic, regardless of whether they're women or men. So in this regard, if we end up with if we enroll 600 Black and Hispanic patients, we may end up with 700 women, for example. And so we'll include all of those. And your first question, what was the first part of the question?
Greg, it was why only Black and Hispanic and not all.
Why only Black and Hispanic? Yeah, that's easy. Our initial application to PCORI actually had all minority group patients, basically any patient that was non-white. And we received the feedback, I think, which is appropriate, that, oh gosh, you're going to have, a small number of Asian Americans, and you'll have even a smaller number of Samoan Americans, or, and a lot of rarer subgroups. And that's going to dilute out the ability to get a consistent message. And they actually kind of wanted us to have one subgroup, but a minority subgroup. And we were able to convince them that we should look at both Black and Hispanic patients. One's a race, one's an ethnicity, and they accepted that. So we can still enroll Asian women, for example, and we will look at the outcomes of those minority patients who are women that are in the trial. But the main recharge minorities as Black and Hispanic.
Thank you very much. Very interesting question and answers. Azim, would you like to go with the next question?
Yeah, sure. Hey, Greg, good to see you
Hey,
again.
Azim, how are you?
Yeah, good, thanks. So, Greg, I may have missed it. I apologize. I joined a little late. But one of the concerns I always have when we do studies of multivessel PCI to cabbage is the lack of consistency of how PCI is performed, which often leads to variable outcomes. So, are you guys providing any guidelines in this? I mean, for example, intracoronary imaging. Just
Yeah.
use that one. That's now uh, a class 1 recommendation according to ESC in this kind of patient, this kind of group of patients. Is that obligatory in this study, or is the PCI strategy left to the operator?
So for the most part, we're relying on standard of care at each individual site. For the most part, we have you use intracoronary imaging. Intracoronary imaging is strongly recommended to be used in all patients during PCI and is mandatory for left main PCI. But it's, again, strongly recommended for others. And similarly, we have recommendations with what to do for antiplatelet therapy, but we've not mandated it. So, the idea for most of these trials is, you take, for example, ischemia as an example with, 320 sites, is they really reflect the practice overall. And it doesn't mean that Montefiore might not get slightly different results depending on, the practice of PCI and cabbage at that institution than the entire trial. But ultimately, that's how you interpret the results of the trial. Is it applicable to my own practice? So we did volunteer, Zim, that you would go to every center in the trial and perform all the PCIs, but so far nobody's taken us up.
But
I don't know,
Dr.
Mario, you might want to make a comment too about what you've mandated versus recommended for surgical
For
practice.
surgery, yeah.
Yeah, because clearly the same apply to surgery as him. And as Greg said, we want to be pragmatic and reflect practice. So we have a pretty detailed procedural protocol for both PCI and CABG. We make a number of recommendations, but we do not mandate except very few procedural aspects. However, the plan it will be to have a PCI oversee committee and the CABG oversee committee, and those committee will work with the site first of all to answer a potential question by local PI, oversee the quality of the procedure and clearly deal with potential outliers in terms of the quality. So we will do everything possible to assure high quality of both intervention, and we will do the same for medical therapy, quite frankly, because we also want medical therapy to be as cutting edge as possible in both arms. So this is all now in preparation because it will be applied in the full phase. And actually, when it's actually one of those areas where, as Greg mentioned, there will be leadership opportunity because those committees are being put together in those months.
Great, thank you.
Thank you very much. I was going to ask a question about medical therapy that is also very important. So glad to see that's taken into account. We have a question from Carlos Rodriguez, and I will ask my question that is in relationship to that as well. He says the STS and syntax scores for coronary anatomy, complexity, and surgical risk are used clinically to determine PCI versus CABG. He asks, how will you assure that you get similar STS syntax scores in each randomized group? And my question that is related to that is, like, there has been a lot of debate between including sex or not in syntax and in scores in general. What are your thoughts in sex and ethnicity in these scores?
Well, this is a randomized trial. So, any parameter we expect to randomize similarly between the two groups. So we're actually asking you to calculate the syntax score. However, we don't want you to rely on the syntax score to determine whether a patient should get PCI or get CABG or get randomized. because again, most of the data we have in that regard is from white men. Now, there are some patients that have such simple lesions, okay? Let's say someone's got a second multivessel disease with a 80% focal secondary OM lesion and an 80% first diagonal lesion that you say, I cannot justify sending that patient to surgery, okay? Or somebody's got such, severe dementia or does have, some sort of cancer, and the surgeons just do not want to operate on that patient. Okay, so those patients there are not equipoise. Or someone's got a syntax score of 57 and two total occlusions that you don't think you can open, and it's so complex that you say, no, there is not any world in which there's equipoise in this patient. That patient should go to surgery. But in general, for many, many patients, the kind that I would go almost back a decade ago, that we were randomizing before we knew what we thought we knew today about the relationship between STS scores and syntax scores, whether it's syntax score 1 or syntax score 2. Again, cast a very broad net, and you might send a few patients to surgery that you'd otherwise do PCI on, and a few patients who would otherwise get surgery might get PCI with a syntax score of 34 or 40. But again, that's all going to balance out, and we'll learn a tremendous amount of, survival, quality of life change in these underrepresented patients.
And also, Greg, I think it's important to remind that we want to be pragmatic, and we do acknowledge that there are variation in practice, right? And so depending on local expertise and local practice, there may be patient of different risk category that undergo one intervention or the other, and we want to capture that, and we think this heterogeneity is important. However, randomization is stratified by center. So at each center, we are confident you will have balanced STS and syntax score between the trial arm, because that the practice at that center will be most likely consistent. And like as Greg said, then we will also evaluate variation by center.
Thank you very much. And I think we have another question from Mario Garcia.
Yeah, so I think it's related, similar to the prior question, which is always a concern with this trial designs, is that certainly there might be this number of patients, don't know how large the cohort would be, but that will be felt to be poor candidate for surgery that will not be enrolled in the trial, and then you have a selection bias towards a lower risk patient population to be enrolled. Would you at least consider keeping a registry of the patients that are not randomizable?
Yeah, so we are keeping a registry of patients who are either women and or Black and or Hispanic who have left main or multivessel disease. And all those patients should go into the registry if they're not randomized. And the registry collects in detail the reasons that they weren't randomized. Either they have one of the exclusion criteria, or they don't meet all the inclusion criteria, and there aren't too many others. And we'll collect those reasons, or the doctor refused, or the patient refused. And if so, we have follow-up detailed questions. Well, why did the patient refuse? Et cetera. So we're trying to collect that, and basically we'll collect the baseline demographics on those patients, but we're not collecting outcomes. Just a matter of cost, where we had to focus our dollars. So we'll understand how applicable the trial is to all patients who are Black, women, and Hispanic, and have left main or multivessel disease. And again, there are some patients that are going to be very valid not to randomize. You take a bad patient with COPD that you said, I don't care if it's a man or woman. A surgeon will say, I don't know that I can get this patient extubated. That's a very valid patient not to randomize, and you would put as an exclusion criteria, you would explain that. But regarding most patients with anatomy, again, we'd like to see low syntax score patients randomized. We'd like to see high syntax score patients randomized, unless they are really at the far ends of the spectrum.
Great, thank you very much. Well, that was a wonderful lecture. We really enjoyed the discussion as well. And we hope to see a lot of patients from Montefiore as well in this trial. And congratulations for the effort.
Terrific. And Mario and I are around anytime, so please reach out to us if you have any questions on any patient, or you want us to speak with anybody. We're here to work with you.
Yeah, and I think Montefiore is in the final stage for opening, so we would should see each other relatively soon for the site initiation visit. If you can just maybe check on your end where the team stands and make sure we can open sooner rather than later. The pilot phase will be over in November, and it's really critical to have you guys actively contributing during the pilot phase also, because that will also give you important opportunity in terms of trial leadership and playing a major role in the trial. So let's try to get Monty open as quickly as possible. Okay?
Yes, thank you very much.
Thanks, everybody. Ciao, Greg. Always good to see you. Bye-bye. Bye.
Bye-bye.
Bye.
Bye, Mario, Greg.